services to the elderly and end-of-life issues in particularly. He was the Counseling and Social Services Manager for Odyssey Healthcare in San Antonio for 7 years, is a facilitator of bereavement groups for the American Cancer Society and the Alzheimer's Association, and is chairman of the Clinical Series for Social Workers Committee. He's president of the Funeral Consumers Alliance of San Antonio, received his bachelor's in social work from the University of Texas at El Paso, and his master's of science in social work from UT Austin. And I'm actually going to let him, if he would so kindly, introduce his colleague, and then in true collaborative style, he will be doing all the rest of the introductions and speakers for the day.
The San Antonio Meat Company has asked that they use this room as a refrigerator, so the temperature has been adjusted, so it should be warming up. Would like to introduce my colleague who will be presenting with me on the ethics in geriatrics, Claudia Fine. Ms. Fine has worked in the field of elder care for over 20 years, was a partner with the New York City-based Fine & Newcomb Associate, which was a pioneering firm in the private elder care field. Her company was acquired by SeniorBridge in 2000, and she became a founding member of the company. She's the former president of the National Association of Professional Geriatric Care Managers and a current member of the New York Society for Clinical Social Work, Psychotherapists, and the American Society on Aging. Ms. Fine has a master's degree in public health from Columbia University School of Public Health and a master's degree in social work from Hunter College School of Social Work. Ms. Fine participated in the developing of a new policy report by the International Longevity Center in the USA that calls for major reforms in the U.S. healthcare system to meet the needs of senior citizens. Claudia Fine.
When Russell asked me to come and join him at this talk, I think my first instinct was, I don't really know anything about ethics. I'm a social worker, I'm a psychotherapist at times, I'm a manager, I'm a supervisor, but I'm not an ethicist. So this seemed to be like a challenge. Russell and I hammered out, like, what could I bring to the discussion of geriatrics and ethics? And yet, as I started to think about what my experience has been over the years, I realized that actually ethics is sort of a soup in which I swim on a daily basis, on an hourly basis. I think we as social workers, care managers, physicians, basically have to wrestle with incredibly complicated decisions about what to do with and for our clients and our patients. So for me, my focus is I would get it done work. So my whole professional career has been about solving a problem and trying to have a clear vision about where we need to go, you know, when the problem is presented to us, how to sort through the issues. And so the skills that I use for that is to focus and to analyze and to advocate. What I've learned over 20 plus, thank you, that's sort of kind of minimizing, but 20 plus years, is that reflection is really something that we need a lot more of. And so reflection is something that is necessary because it's not just our clients that we have to deal with in geriatrics. I was sort of struck by, you know, the preceding speakers that we were really talking primarily about the patient, primarily about the patient's right to choose, the patient's right to decide, and the patient's ability to decide. But as I work in the field, I'm struck by all of the stakeholders in this process, and that there are ethical decisions that impact all of them. So, I've been quoted as saying, this really is brain surgery. So let's go on and approach this issue of ethics in geriatrics.
Can you turn the volume up
Can I? I don't know.
a little louder?
How do I do that? Gina, I just thank you for stopping me because I wanted to say something else. That, just to give you some sense of sort of, where I come from and Russell comes from and how this sort of impacts our daily life. We provide services in the community. We're not in an institution. And there's, things are moving very quickly. People are coming to us. We're getting calls day in, day out. Crises occur. And we don't really have the support of a structure of a hospital and the support and the ongoing oversight 24/7, that a nursing home has. So, in fact, we've been dealing with these without the benefit of, a formal structure to reflect. And as a result of that, about, almost a year ago, maybe about 8 months ago, our professional advisory board, actually Dr. Claudia, which is a member of that, came together with some other leaders in geriatrics, public policy, psychiatry, medicine, social work, and said, you can't do this unless you have a formal ethics committee. So as we, have been working to put this committee together, we've been basically struck with certain objectives that we have to meet. And this is what we have to accomplish at SeniorBridge, and I think that's what people in this field, in their institutions and in their agencies, need to work with their staff about helping them to understand what's ethics, what are the basic principles of ethics, what's an ethical dilemma, what are the factors that lead to the increased ethical dilemmas that occur in the geriatric population and in healthcare? What are some of those frequently occurring ethical dilemmas, and how do we identify them? And of course, the most important thing is how do you resolve them? So, remember I said that I was not an ethicist and I don't know that much about ethics, so I sort of did a little bit of sort of pretty basic research and found out that basically it comes from the Greek word ethikos, and it means character. So, my interpretation of character actually is, personality. Other people sort of define character as good character and bad character. So I don't have an answer to that. It's just a big question. But to me, it certainly does, the concept of personality, what is the character that we're dealing with, is a very strong, consideration as we dive into ethical dilemmas. So Aristotle, who is the par excellence ethicist, basically said that basically ethical decisions are made by a group of reasonable men, women as well, who know right from wrong. But that the process of transversing ethical dilemmas is so complicated, there can't be a simple, discrete set of rules to follow. Hence, we don't have, a form that we can check off. We don't have, a mental status test. We don't have any of these things. It is really a kind of fluid, complicated process. So, and the reason it's so complicated is that we are balancing individuals' internal moral constructs, and I would also offer the idea that we're balancing individuals' psychological constructs with their obligations to society and group. So these are the basic principles of ethics, bioethics. I did a little bit of tweaking here because I took from different things, but this seems to be a good list. Now we have autonomy. Now we've talked a lot about autonomy, and I, want to thank, I'm forgetting her name, Scott, for bringing up the fact that prior to, 20th century, autonomy wasn't such a big deal. Actually, I'm not sure that autonomy is a big deal. I think the lawyers in this room might disagree with me, but I think it's open for debate. Is it really so important that each person freely determines his or her course of life? You know, I'm being a bit provocative, but I think that, you know, those issues are being challenged in our society all the time. Can we buy trans fat in New York City? You know, that's autonomy. Well, no, we can't. We can't go into a restaurant anymore, and McDonald's has to buy their French fries differently. So their autonomy to do that has been limited. It's been limited because of some of these other issues having to do with ethics. Non-malfeasance, do no harm. Well, that's true if we have one person in the room. So we have one person in the room, and I'm not going to hurt you. But if I'm taking care of you, and in taking care of you, I am somehow creating some harm, and harm is also relative to your daughter. I'm basically being respectful of your autonomy, hence I'm being good to you. But I'm creating tremendous caregiver stress for your daughter, who's up all night worrying about the fact that her mother's going to fall and break her hip. You know, where's the harm, and who are we thinking about here? Justice, what's right and fair. Again, justice is relative also, as we well know. And then there's veracity. Now, veracity is my favorite one because, as some of you know, all of my children are in the arts. They're all in theater. And I feel that actually out-of-work actors are the best caregivers that you can possibly employ because they can take reality and repackage it in a way that's useful and helpful to someone whose reality may be compromised because of cognitive and psychiatric issues. So, you know, when someone comes in and says to me, you know, Claudia, how are you going to tell my mother? What are you going to say to her when you're going to go in and talk to her? You know, are you going to say you're a social worker? My mother thinks social workers are for nutcases or for poor people. Well, I'm not going to say I'm a social worker. I may say that I'm a friend of her daughter's. Is that being truthful? I don't know. These are ethical issues. Okay, so now we lead into those dilemmas. We have to review the consideration of all the facts that support differing conclusions as to what's correct. So I may think that it's completely correct for, you know, for me to tell Mrs. Jones, who is highly narcissistic, you know, early dementia, you know, really needs some assistance in making sure that she's going to take her medication, has always had a housekeeper, but the housekeeper quit because she's so difficult. And I'm going to basically come in and tell her that the caregiver is, you know, a maid. And, you know, are those the facts? And those are the facts. She's not a maid. She's a caregiver. She's a CNA. Now, you know, again, we have to like take all of these different facts and come to completely different conclusions. One of my attorney friends may say that we are misleading that client. Same facts, different conclusion. Both my attorney friend and I think we're right. So there's a collision in terms of our professional code of ethics, if you will. There may be a collision in terms of our sort of psychological states. A case came up right before I left at SeniorBridge. Our care manager felt that we were being unethical because we were spending so much time supporting an adult child and helping her to understand that her mother was not able to make certain care decisions. And then this took a tremendous amount of time. It was very costly. All of his attention we were spending on the adult daughter. And the father, who was the bill payer, didn't want to pay the bill. Therefore, where were the ethics here? Could he choose to not pay for his daughter, who was supporting him in so many different ways, counseling? So there's a collision again. Well, what happened here?
Hit the next button.
Ah, so cute. Very nice. Very nice. Okay, so as we know, in our practices, and I'm assuming that everybody is all in the same place, where these ethical decisions are, complicated, exacerbated by diminished, questionable capacity for decision making. We've learned ways to make that a little easier. Multiple chronic diseases, which is the most important disease to treat? I mean, that comes up all the time. Who's the primary doctor? Who's in charge of this patient? Increased frailty leading to increased dependency. This happens to be my favorite complication. We have people who are, interdependently wound up in a helping, receiving relationship. Frequently they're merged, there's sort of symbiotic stuff going on there, and that creates a whole lot of complicated demands, and who really are we taking care of? The issue of cure versus care. Last night we were discussing palliative dentistry, and the issue of are we withholding, restorative services to people who, because we don't have enough money to pay for dentistry in the community, to train dentists to go out in the community and make sure that people have adequate oral hygiene and teeth to chew their food and be healthy. But we don't. So is it enough to have a dentist who goes out and is able to do screening and triaging? Well, no, it's really not enough, but it's all we have. So those are those, complicated issues. And then, of course, quality of life. Issues of right to die, issues of what is quality. Is it a quality for the patient that Jason mentioned to stay at home and not have the daughter intrude in her life and feel like she's in control of her environment and not take her pills? Is that the quality of life? And then finally, the big one, the heavy consumption of limited healthcare resources. That seems to me to be, this sort of ogre that's hovering over all of these ethical decisions. Way back in the, I guess, 70s, late 70s, when we were dealing with the lady in the box in New York City who basically died because she refused mental health services. And all of a sudden we became really concerned about people's right to check themselves out of a psychiatric center. And we were going to provide a lot of community psychiatry to take care of these people, and in fact, we didn't. To me, these issues of quality of life and right to say no really are very bound up with how much we have to offer to begin with. And I think it's a very, very kind of like difficult tightrope to walk. And we can't overemphasize one of these tenets versus another. So, let's talk about what Russell's going to talk about. And that's essentially what you, we as professionals have to do. We have to essentially ensure the quality of the client's life using these ethical principles, advocate for advocate for the safety of the client and others, reduce the risk to clients and others, and reduce liability, our own liability. We spend a lot of time talking about reduced liability so far, and contain costs, because it's not an endless purse that we have to play with. So I'm going to turn it over to you.
What's interesting is when we start looking at these issues, we end up with a conflict that naturally occurs between somebody who's exercising autonomy, somebody who says, this is the way that I want life done, and yet we also have the issue of, well, is that really and truly in your best interest? And that's part of the issue that competency and capacity butts up against, and why that conflict exists. Then we look at, with the client's ability to refuse services or refuse care, and how that interacts ethically with those. Then the other issue of, well, is it a safety issue? Not just physically, but financially, or looking at other issues for exploitation. The client who decides late in life that they want to get married against the children's wishes. Then we end up with a client conflict on safety and the greater good of society, looking at a driving issue. How many times have we heard family members come to us as professionals and they say, gee, when is it okay for me to take the keys away from mom or dad? And I like to put the question back in their lap and say, well, would you let your children drive in the car with them? No, I wouldn't. Well, here's your sign. We end up with conflicts around confidentiality and disclosure. Had a client going into a hospital just this week. Client had capacity, had the ability to make his own wishes known. He told the staff that he wanted our staff to be informed about what's going on and for us to help drive the medical care. And yet when our staff continued to try to interface with the hospital staff, repeatedly we were denied and saying, no, I'm sorry, we don't have the right forms. Well, we provided them with the forms that the client signs for us, which is the release of confidential information at the beginning. But that wasn't good enough. The hospital said, no, it's not on our form. I said, well, would you get us your form? They said, well, you have to go downstairs and get that yourself. So we end up with a culture in trying to protect our own liability, trying to manage healthcare in a respectful way, but it ends up creating more dilemmas or more conflicts because who's right and who's driving the bus? There are three areas in particular that I want to look at this afternoon that as a professional geriatric care manager, I see it happen frequently that we encounter. And I think as a society, these are things that we need to promote greater awareness in. We'll talk more about that. So we're going to be looking at the financial issues, the legal arena, and the medical areas. Financial. I've talked to many bank employees. They report that on a weekly basis they'll see Mr. Jones, who's an elderly gentleman, come into the bank making transactions that seem questionable. But the employee feels reluctant to address the discrepancy for fear of offending the client. And because the bank employee doesn't feel she has the right to question his decision, because he seems to make most of sense all the time. So we see this issue with the financial industry where somebody suddenly is saying something smells funny here. There's something not right. And yet they're reluctant to step in or even call attention to it, even if this is the third time today that Mr. Jones has come into the bank. So we end up with somebody recognizing that there's a problem, but not having the capacity or the authority in their own job description to be able to make that change themselves. Some of the signs that we see that we want to be aware of, the clients who come in and are making loans to caregivers, they're adding the caregivers to their own bank accounts. Well, I really can't get into the bank as often as I want, so I'll just put my caregiver on the account and everything will be fine, right? The caregiver's going to the clients and saying, gosh, things are a little tight this month. I'd like to come and visit more often, but I don't have enough gas money or I can't make my car payment. So the client says, you know what, let me just make your car payment for you. Be happy to do that. One situation that I've encountered was a caregiver who had managed to get access to the client's ATM card, was making withdrawals for herself. The family felt really sorry for the caregiver and she was telling them how difficult things were at home. Well, the family had bought new appliances for their mom, and they decided to give the old ones to the caregiver just as a way of helping her out. The caregiver says, well, I can give you some money for it. They said, well, that would be fine, whatever you feel is appropriate. She went using the client's ATM card, took out $150 and gave it to the family. These issues with the interactions of the clients in the financial institutions, where the members of the banking industry are aware that the clients are coming in. This happens on a regular basis, where the clients, the banking employees are saying, you know, this doesn't seem right. This is somebody else that she's bringing in yet again, making changes to the account, or seeing unusual changes in spending habits. In the legal arena, we end up with some interesting situations as well. The pervasive assumption that the client is competent until the courts take that right away makes it difficult to deal with a client who lives alone and is refusing assistance to give or receive care. The client may be reluctant to complete advance directives or even attend capacity screening appointments. Citing their desire to preserve their savings for the children, the client can refuse to spend money for services which would enhance their safety or prolong their independence. In one situation that I thought was very interesting, we had a very large family. All the children lived out of town. One of the sons came in to visit with Dad. When he was talking with Dad, he realized that Dad needed some help making financial decisions. So he said, you know what, Dad, let's go down and we'll get power of attorney set up for me. Not a problem. Dad says, okay. Now, Dad's got just a little bit of dementia. So Dad put son on power of attorney and got him on all of his bank accounts. A month later, daughter number 1 comes in town, visits Dad, and says, you know what, I don't like the decisions that brother's making. Not that there was any exploitation, she just didn't agree with the way that things were going. So she said, Dad, can we go down and put me on your bank accounts and make me power of attorney? Dad said, oh yeah, he's very agreeable, fine. So they go down to attorney number 2. Get a new advance directives, new power of attorney, put daughter number 1 on bank account. Daughter number 3 comes in town 2 weeks later, does the same thing. So suddenly, Dad walks into attorney office number 3 with the daughter number 3 and says, we want to change. Where are the checks and balances in a system where the client may have capacity, but yet when you look at the greater picture, there's a little question that needs to be asked about, is this going in the right direction? And again, in that situation, there was no harm being done. Everybody's intentions were good, there was no exploitation. But the question remains, is this truly, all these changes, in the best interest of this situation? So a good question that I love to frame for my staff and for families when we are working with these issues is, who's the client? Is it indeed the patient that comes in? Is it the family? Is it the daughter? Or is it the family system as a whole? How are we deciding how the money's spent? What happens when we have the disputes over assignment of power of attorney? And what about the client who is reluctant to complete directives? An interesting situation that occurred, I was called by a bank trust officer, asked to go see if we could get caregiver services started for Mrs. Jones because she was living in a home by herself. Neighbors had been complaining for weeks that Mrs. Jones is wandering the neighborhood and sleeping on the This was a little unsettling for the neighborhood. There was a son involved, but the patient, the client, Mrs. Jones, and her son didn't get along very well, and every time she saw him, she would scream at him and tell him to go away. One time he tried walking towards her house, and she saw him and tried to back over him in the car. Her dementia was such that she could make sense in the present, but if you came back those 30 minutes later and checked again, you'd find, gosh, this one, she wouldn't remember me, and two, were a little worried that anybody else could walk in and make the same situation happen. So my first visit was with the client's son. We talked a little bit about his understanding of what was going on. It was obvious that Mom's safety was in jeopardy because of the situation. He acknowledged that Adult Protective Services had been involved, but they were taking a path of least resistance and trying to see if the situation will resolve itself with all the parties working together. He acknowledged that there were power of attorney assigned for medical care and financial, but it was to a clergy member from her church that she went to about 2 years ago. And the secondary on that was a parishioner. Well, that clergy member no longer is in town anymore, has no more contact with the client. The parishioner has told him, I don't want to have anything to do with your mom because she's crazy. Having as much information as I could get from that situation, I decided next to contact the client's attorney, since that was another principle somebody had let me know about. When I talked to the attorney says, you know, 6 months ago she asked me to draw up documents making her son medical and financial power of attorney because that was what she wanted to do. So I've drawn those documents up, I have mailed them to them, however, not received them back. I go into the client's home, introduce myself. She talks about the evil caseworker from Adult Protective Services and is absolutely right. We want to keep her out of your life, and that's what I'm here to do. And here's how we're going to do it. We're going to get some people over here, and as long as you have these people here, that evil lady from APS isn't going to be able to come and take you away, take over. She says, okay, we can do that. I said, all right. Happened to look at the coffee table, and there on the coffee table is the envelope from the attorney's office. I said, by the way, I talked to your attorney on my way over. And she said that she would like me to make sure that I got these documents signed for you so we can send them back to her. She said, well, what are they? I said, well, you remember a couple of months ago you called and said that you wanted these documents put together, and you asked her to do that. Oh, yeah, that's right. Well, would you go ahead and sign them so we can take them back? So put the documents out on the table. She was kind of looking over them. I said, by the way, that's a lovely bird bath you have over there. Oh, yes, it is. She picked up a pen and signed the documents. The question that I wrestled with on an ethical level, did she have capacity to sign those documents? Was there a violation because I had her execute something that she had asked her attorney to do earlier? It's a big challenge because if the only way that we can address this issue is by saying this client has not had her rights removed from her, then she does have the ability to sign for herself. And so the question, who's the client, for me is a big one, because is she the client? Is it the trust officer? Is it her attorney? Is it the family at large? When we look at the medical setting, too often clients are asked to make decisions for themselves regarding their own care when they don't have good judgment or decision-making capacity. And yet the system looks to them to direct their care. Many times the issues are not of paramount significance, like bathing or medications, or accepting assistance for even a few hours at a time. But they pose significant concerns for ongoing care. The examples would include driving. What is the responsibility to the client? What's the responsibility to the public? Medication management is another. Some of the signs that we want to be aware of is when we have a client that is denying or refusing services that are needed. And I love the discussion this morning about what a reasonable person would say is needed. I thought Dr. Karlwich's observation that reasonable usually means the person with the most power. If you have a client that's missing multiple appointments, or they have chronic calls to the office. A lot of times when I'm working with the doctor's offices, the office staff will talk about Mrs. Smith, who calls repeatedly, several times a week. And yet there's nothing that they can do for Mrs. Smith. She just needs to call and talk to them. So that's an indicator that perhaps there's something going on that might mean we need to take a better look at what's happening in the home, or when we see medication disparities. So faced with these kinds of situations. What do we use as a rule of thumb or a guideline to help give us direction on how we need to approach them? Best thing to do is gather the known facts and objective observations. In my example of the woman who was at home and had been wandering the neighborhood, sleeping on neighbors' porches, part of my work, even before I met with her, was to talk with the trust officer, talk with her family, to talk with the attorney, to get a big picture idea of what was going on, to involve APS because they were on the sidelines saying, we know she needs help, but we're hoping that you guys can make things happen first. What are the relevant ethical principles? We certainly have the issue of autonomy with any client. Then we also have the issue of benevolence. Are we trying to do what is good for her? Is it good that she's not sleeping on her neighbor's porches? Is it good that we have the advanced directives giving her son the ability to help with medical decision making, to facilitate what's going on? Non-maleficence. Are we making sure that no harm is coming to her? That we are putting in position in place those mechanisms that will help keep her from being exploited or having safety issues arise? And then, for me, the challenge is also adding to that, what are my personal values and beliefs? Or significantly included in this also are what are the organization's directives? In doing hospice work, it was always fascinating to me to see that the agency's need is we have these forms that are assessments and we need to get them complete. And so your job as the social worker, you have to go get these documents done. They need advanced directives. You need to go get advanced directives from them. Well, that's an organizational need. It's not the family or the patient's need. And so having to find ways of balancing those issues, be them personal or institutional beliefs, has to play a part of that as well. Who are the other stakeholders? What are their values and beliefs? We just received another call this week from Adult Protective Services. Got a client that's living at home, has no family member. One of the neighbors has been helping out, overseeing doctor appointments, paying bills and stuff. The neighbor's getting a little frustrated because the house really needs to be cleaned. She set up a cleaning service to come out. However, the client, after agreeing initially, has now recanted and said, no, you can't send anybody over to clean the house. I won't let them come in. Adult Protective Services says, well, we know that there is a bank involved. So we called on a conference call and got the banker, the neighbor, and the APS, the neighbor, and the banker all on the phone call. And started trying to ferret out who wants to do what, getting everybody a big picture. Now, it was interesting. The very first statement out of the banker's mouth was, I have financial power of attorney. I said, wonderful. That makes things so much easier. And so as we got around to the end of the call and started making assignments, I said, great, then if you have financial power of attorney, would you be okay authorizing for us to come in and provide services? He said, well, I really don't have financial power of attorney, but I can help pay your bills. Okay. Well, is this a bill that you can help pay? Well, I can't pay her bills unless she authorizes me to. Okay. So suddenly, it's like, okay, you're not a player after all. Thank you for coming. Here's a consolation prize. Go away. We end up with the conflict because nobody is able to stand up and take responsibility for this person, yet there is a great need that exists. So what we were able to do at the end of that call was to tell APS the process. That is absolutely necessary. There has to be a decision maker in this. We can't continue allowing her to refuse services when they're needed. And so they will go ahead and get the psyche eval started. The other conflict exists when we found that the man who said he had financial power of attorney actually didn't. However, the solution to that was he was meeting with the client, actually is meeting with the client this afternoon. And so what we're able to do is we dropped our forms over to him. So when the client and the neighbor are meeting with the banker, he will present the forms allowing financial consent for payment of our bills so we can become involved to start trying to access all the systems and making things happen. So who's the best person to resolve the conflict? Sometimes it takes somebody else standing up and saying, I'm going to help coordinate and orchestrate. Because all the little players are unwilling to stand up and say, I'll do that. I'll act in a way that facilitates change. What are the possible implications or consequences for each of those decisions or actions? For me, I could spend the 2 hours that we worked on it yesterday and then another hour probably today. If nothing comes of the case, then that's all I'm out, is my time. However, the other side of it is, if it works, then we have some support for this person and have a plan, because that's what we're here for. We're here to make sure that those that are vulnerable, that are in situations that can be exploitative, that we are able to help put safety mechanisms in place. Then we want to help to decide on a course of action and implement it, and evaluate and monitor the outcomes. So when we are looking, whether it's the banking industry, and many of the large banks do have some type of training for their staff to look at the issues of elder abuse and exploitation, we're really hoping that we can start bringing to a greater awareness the need to put together policies and practices in those institutions to help provide a greater sense of security, so that when Mrs. Jones comes in for the third time putting another caregiver on her bank account, or that when she wants to take out a large sum of money and there's somebody with her that nobody recognizes, that we have the ability to say, you know what, we need to check with somebody else before we can go through this. We need to do the same thing with both the medical and the legal systems as well, so that when we have the client coming into the third attorney's office, we have some ability to say, you know, there's got to be something going on, because this is the third one that we've done within a couple of months. And without that continuous monitoring and evaluation of the systems and the practices, we have no feedback or no way of knowing how effective our efforts are. Any thoughts or comments? Oh, wait a minute, one more. I thought there was. So what we're looking for, what I'm asking for, is increased global awareness in these service industries about the potential ethical conflicts associated with the geriatric population. We want to develop those basic industry-specific screening tools to help identify clients at risk. Also put together protocols for processing these conflicts and policies to identify the problems, and then implement and evaluate the effectiveness of those interventions as well. Questions, thoughts, comments?
You mentioned that some of the larger banks do have training programs, because I've run into this issue before, and the bank managers have told me, we really aren't authorized to evaluate capacity, so therefore, if he keeps bringing his son, who comes over once a month right after the Social Security check arrives from Las Vegas, and cashes it with his son telling him to, I have no ability to say, to do this, anything about this.
Right, and that's one of the more frequent comments that I hear from the bankers is saying, but we don't have the authority to tell her she can't do that. And that's where I think it becomes, the question for me becomes, well, if it smells funny, maybe we need to check. And that's all we're asking for. We're not asking you to not help or not allow that person access to their own funds. But if there's something that is unusual, we need to be able to put practices in place to call attention to it.
Talking to people on a one-on-one basis, is there any way of going upstairs to B of A or Citibank?
Part of what I have been doing locally is talking with some of the banks. Guarantee Bank is one of them locally that I've had conversation with, and I'm reviewing some of the training materials. And I'm trying to encourage them to invite me in the next time they do one of these to say, why don't we consider doing this, this, or this? And maybe on that level we can start implementing change.
Just share a comment on that. You know, in New York there was there's a policy that has to be done at a state level. One of the big problems is the proverbial bang form. you know, you need to do it on our form. Well, actually, the law is in New York State that that's not true. That in fact, if you have a certified power of attorney, you can bring in, it doesn't even have to be an original, it just has to be certified by the lawyer. So, you know, good elder law attorneys make like several certified copies, and the bank really has to honor that. However, you need the lawyer to get on the phone and fight that, because they won't. But the law is that they have to honor it. That's unfortunately not the case with, you know, investment firms and, you know, the Smith Barneys and the, you know, whatever. But so yeah, these things have to be done on a, you know, policy basis.
I think we might have more attorneys in California than New York, I'm not sure.
Okay, thank you. I have two questions. The first is, what is the likelihood that a person who lacks capacity in medical decision making, for example, also lacks capacity in the other areas, like medical and legal? And then the second question, if a person does lack capacity, what is the professional's role to seek a decision maker, especially if no family members come forward?
The issue of the difference between financial capacity and medical decision-making capacity still confounding to me. It's almost as if there is two separate standards where we say, okay, you really can't write checks, but you can't tell me that you don't want anybody to come help you manage your medication. It makes it difficult because and I think that that's part of what I was excited about in listening to Jason's presentation this morning, is we're starting to develop our screening instruments to get a little more exact about exactly what capacity really means. And I think as we develop better assessment tools, we'll have a better ability to make a distinction clear on those issues. It still is difficult. And the other question?
But we don't want to make an assumption, right, that if they are lacking capacity in one area, that they're automatically not
Correct.
able to be. Okay.
Correct. And the other question was?
The second question is, so if you determine a person lacks capacity in whatever area, and as a professional, then what is your role in seeking out a decision maker, especially if there's no family member that you can identify or that comes forward?
Right. And that gets really challenging. Well, you're absolutely right. However, somebody's got to be able to do that. I'm hoping that with, and I know the next presentation with Ms. Whitehead, she'll be able to talk about these as well, but that's part of what we're needing is once we've gotten these issues better defined through assessment tools, and we can say this person lacks the ability to make these types of decisions, but they can make these types. Then we have the ability to say we need somebody else in charge to help guide and direct those issues. When you don't have anybody as a professional, what do? I start checking around. Usually what I found is if nobody's objecting, then you can get that neighbor to continue to make those decisions. And I as an administrator, part of what I've done as well in the past is encourage, when I train my staff, I don't want you to have to make these decisions on your own. Bring them back to the team. Let us as a group sit around and talk about it, because there's more collective wisdom than there is in any one person. And so as a group and as an administrator, then I can say, yes, that is a risk that as a company I'm willing to have you take for us, and I will have you back on that issue. Very good. Thank you very much.